Thanks, Nancy. All right, well, let's get started now. I'd like to introduce our guest speaker today, Dr. Jennifer Cope. Dr. Cope is a medical officer at the Centers for Disease Control and Prevention and a commander in the U.S. Public Health Service. Dr. Cope began her career at CDC in 2009 as an Epidemic Intelligence Service officer assigned to the North Dakota Department of Health. Dr. Cope obtained a BS in microbiology from Penn State University and received her medical degree from the University of Pittsburgh School of Medicine. She completed residency training in internal medicine at the Emory University Hospitals and Grady Memorial Hospital in Atlanta, and infectious disease fellowship training at the University of Maryland Medical Center in Baltimore. She is board certified in infectious diseases. Over the past year and a half, Dr. Cope has served in many roles as a part of CDC's COVID-19 emergency response, including leading a unit dedicated to the study of post-COVID conditions or long COVID. She is currently serving as Deputy Chief Medical Officer on the CDC COVID-19 response. And I'm really excited and grateful that you took time this morning, Dr. Cope, to speak to the National Coalition of Autoimmune Patient Groups. And I will stop talking and turn it over to you. Thank you.
Yeah, thank you, Brett. Thanks for that great introduction. And thank you for the opportunity to speak with everyone today. So let's see. Yes, there's my first slide. It's a pretty broad ranging presentation. So gonna cover, a couple different topics. I know Brett and I spoke earlier about some topics that may be of particular interest to this group. So hopefully I'll hit on some of that. So yes, go ahead, next slide. All right, so I'm gonna dive in just to covering kind of the current situation, where we are at in the pandemic right now. Next slide. All right, you might be familiar with these figures, but just giving you an orientation, these are what we call epi curves. And so these are the number of cases of COVID-19 over time. And what you're looking at is both cases on the top and deaths on the bottom. And you're looking at the entire course of the pandemic. So to the very left of the screen, you see the beginning of in January 2020 and going all the way through just the beginning of this week. And I show this view because I think it really kind of highlights the roller coaster that we've all been on since the beginning of this pandemic. And so I'll point out a couple. You see kind of the peaks and valleys we've all been through. I'll point out the biggest one there in the middle. That represents that winter surge that started at the end of last year and kind of peaked in the winter in January and then started to trail off. What that also coincided with was the introduction of these vaccines that we now have. We started vaccinating the first frontline folks and nursing home residents at the end of December last year and into the early part of this year. You kind of see where we were at the beginning of the summer, that low point, and then you now see what we've been through, this Delta wave, as we call it. And I'm happy to be here today to say that, things are looking optimistic again. We've had several weeks of consistently declining cases. Which you can see at the red line there starting to trail off. Deaths, which have always been a lagging indicator, are just now starting. Today in today's data, I saw that deaths are beginning to decline as well. So happy to say we're seeing some optimistic numbers after this Delta wave we've all been experiencing. So next slide. So kind of highlighting what the last few months have looked like. I think earlier this summer, I think we had a lot of hopes for something, that looked like maybe a normal summer. Early July, less than a quarter of counties were in the substantial to high levels of transmission, and that's represented by these orange and red colors. And so you see the map of the US in July was very multicolored and with a lot of yellow and blue representing low and moderate transmission of COVID-19. And then over the course of July, nationwide cases rose steeply by over 400%. And so by the end of July, over 2/3 of counties were in the substantial to high level of transmission. And you see that with more and more of that red color predominating, particularly in the South. Looking back at the map on the left, you can kind of see the beginnings, of the Delta wave, which started in Missouri and Arkansas, and you can see the red there even in early July. So next slide. And here's where we currently stand. As you can see, it's a very red map right now. So most counties in the United States are now experiencing high transmission levels, over 97% as of the beginning of this week, at substantial to high levels of transmission. But as I said, starting to see some improvement in those numbers. Next slide. And this is the reason why we at CDC are tracking the SARS-CoV-2, so that's the official name of the virus that causes COVID-19. SARS-CoV-2 variants are being closely tracked, and we track which ones are circulating. And this shows you, so the Delta variant is in this orange color, and on the map on the left, we have these pie charts showing the proportion of variants circulating in each region of the United States. And you can see it's just all orange. They look just like orange circles. There's not much else to the pie. And on the figure on the right, you can kind of see it starts around the end of June, where you can see there were a couple of the other variants still circulating, that B117 or alpha variant from the winter surge. But you can start to see Delta taking over and then moving all the way to the most recent date on the right. You pretty much don't see any other variant circulating. So next slide. This is a very interesting figure that I think we added to our COVID data tracker pretty recently. And this really highlights the mismatch we're seeing between vaccination and test positivity levels. So this is the percent of tests that are returning positive for COVID out of all the tests being done. And so to orient you, we have this grid on the left. And down in the bottom right corner, we have, again, red color, probably sensing a theme. Red is not the best color. And this red, the red color indicates the areas with the greatest percent positivity and the lowest percent of fully vaccinated population. And then on the other corner of the grid, you see the nice aqua green color that represents the lowest percent positivity with and then corresponding to the highest percent of total population fully vaccinated. And then you see the varying shades in between. And so when you look over on the map, again, we are seeing that red color throughout the Southeast United States, as well as some other pockets in the Midwest and the Mountain West areas. And then you really see that aqua green color predominating in the Northeast, as well as along the West Coast. And then you see kind of the in-between colors throughout. I think it's also interesting to see my home state of Pennsylvania with looking very multicolored there. And I think it just shows kind of how local some of what we see is. When you drill down by county, you can really see some differences. Next slide. And finally, so we have a map. This is just percent vaccination status. And this really, again, shows local vaccination rates varying substantially across the United States. Here we have shades of blue, with the darker shades of blue representing the more highly vaccinated parts of the country. As of Monday, September 27th, we had nearly 184 million people vaccinated. This represents about 2/3 of people 18 years of age and older. Next slide. So a little bit more about Delta, because this is why we are where we are right now. This Delta variant, what do we know about? What is the science saying about this variant? The main story about Delta is that it is far more contagious than previous strains of the virus. In fact, it might cause more than 2 times the number of infections of the original strain. And we have a nice graphic here showing what that looks like visually, where the original strain on the left might have, a person infected might have passed that infection on to just 2 people. The Delta variant can do upwards of, 2 times or more, so that you can see how many more people can be infected by just 1 person. The good news is, and you might hear me say this a lot throughout, so hopefully our message is getting through, but the vaccines continue to look really good as far as protecting from the most serious outcomes of hospitalization, severe infection, and death. Next slide. So for people who are vaccinated, we did learn earlier this summer, and you might have seen kind of the highly publicized report out of CDC around the Provincetown outbreak in the Cape Cod area of Massachusetts, where we really did start to see these breakthrough infections of Delta in people who are vaccinated, and that these people, even if vaccinated, can be contagious and transmit the infection. However, overall, people who are vaccinated are much less likely in general to get infected and then transmit the virus to people who are unvaccinated. Next slide. And yeah, so the news is not as good if you're unvaccinated with Delta. Data suggests that the Delta variant might cause more severe illness than previous strains in people who are unvaccinated. This is still probably a very active area of investigation. Teasing apart the more infectious nature of it from the severity has been an ongoing challenge. But people who are unvaccinated are at greatest risk for severe infection, hospitalization, and death. Well, people that are vaccinated look like they can be contagious and transmit the infection. It looks like it's actually for a shorter period of time. So people who are unvaccinated appear to be infectious for a longer period than people who are vaccinated. And that's, obviously that is ongoing risk for transmission if it's for a longer period of time. The highest spread of cases during this Delta wave and the most severe outcomes has been happening in places with low vaccination rates and among people who are unvaccinated. I don't know if I know I was seeing a lot of the local hospital systems were posting on social media about their COVID hospital census numbers, and then they were breaking those out by the number of vaccinated and unvaccinated, and it was overwhelmingly the unvaccinated who were in the hospital with COVID. Next slide. Whoops, one back. There we go. So what can we do? Oh, you were good there. Yeah, the one with the people with masks. Getting vaccinated is going to be the best bet against preventing severe illness, hospitalization, and death, and also helping to reduce the spread in communities. I'm going to talk more later on in the presentation. I know additional doses of vaccine as well as booster doses are very hot topics right now. There's been a lot of new recommendations along those lines. But the main emphasis, our primary focus at CDC is really on the quarter to 1/3 of the US population who still hasn't even gotten 1 dose of vaccine. That's going to make the biggest impact on this pandemic, is getting the people who haven't gotten even 1 vaccine yet, getting them to start that vaccination series. Boosters are definitely important, but it's really getting the primary vaccine series to everyone, as many people as possible. And then the other thing that we're, in areas of substantial or high transmission, which you saw the map showing that still is the majority of the United States, everyone should be wearing a mask in public indoor settings to help prevent the spread of this Delta variant. And so that's one of the other main recommendations we have right now. Next slide. So I know this group is particularly interested in the impact of COVID-19 on the immunocompromised population in the United States. And so a couple of things that we do know for sure about this population and SARS-CoV-2, the virus that causes COVID-19, is that they are more likely to get severely ill from COVID-19. They are also at higher risk for prolonged shedding of the virus, as well as higher risk to develop only low antibody or neutralization titers against the SARS-CoV-2 variants. They're also more likely to transmit the virus to their household contacts, And a high proportion of these vaccine breakthrough cases are occurring among immunocompromised people. Next slide. So here's a couple of topics I'm going to touch on around the immunocompromised population. I want to highlight a few areas of CDC communication and resources that you can go to that address this population specifically. Talk about some of the reopening guidance we have that accounts for the immunocompromised with a little mention about school openings. I'm definitely going to be talking about the additional vaccine doses that were recommended last month for immunocompromised and look a little bit at the data for vaccine efficacy in these populations. And then I'll touch a little bit on the monoclonal antibodies for treatment and prevention. Next slide. All right, so next slide. This is one of our websites that does specifically speak to immunocompromised, people living with immunocompromising conditions. This is a website with people with certain medical conditions, and it's linked there at the bottom. And one of these categories is people with immunocompromising conditions or weakened immune systems. Next slide. On our When You've Been Fully Vaccinated website, we also talk about people who have a condition or taking medications that weaken their immune system. We caution that they might not be fully protected even if they have had the full vaccine series, and that they should be taking all the precautions that are recommended for unvaccinated people. And this does include wearing a well-fitted mask. And then also it recommends the additional dose of the mRNA COVID-19 vaccine, which I have some additional slides about. Next slide. And then here's just a couple of other websites across CDC's COVID-19 web content that address, have areas that address people living with immunocompromising conditions and advice for them. Next slide. All right, so getting a little bit into this new clinical guidance about the additional dose of vaccine. Next slide. So in these interim clinical considerations that came out back in August, they added new and expanded sections that include considerations for using an additional dose of COVID-19 vaccine after the initial 2-dose COVID-19 mRNA vaccine series for immunocompromised people. And then they also were some considerations for vaccinating people with certain underlying medical conditions. And so what this recommendation was and I want to talk about this additional dose versus booster, because there is some distinctions being made. The additional doses for people that who are unlikely to have mounted kind of that full antibody response to the initial 2-dose series, like we would expect for someone who has a fully functioning immune system. And that additional dose can be given 28 days or more after that second 2-dose series is completed. CDC had a COCA call. This is our clinician outreach and communication activity that was held on August 17th to really spread the news about this recommendation to clinicians and clinical and public health partners about this new guidance that came out from our Advisory Committee on Immunization Practices, or ACIP. Next slide. So this next few slides, I'm going to delve a little bit into the data that they reviewed to make this recommendation about an additional dose. So next slide. So these are, this table is showing 4 studies that looked at immunocompromised populations. This compares the antibody responses after the second and then a third mRNA COVID-19 vaccine dose among people who are immunocompromised. So on the far left, we have the patient population, which 2 of these looked at solid organ transplant recipients, and then 2 of these looked at patients on hemodialysis. And you'll see in the middle column, this is after the second dose, and this is breaking out the people who were considered seronegative, meaning they did not develop a detectable antibody response, and those that were seropositive. So you see that there were some people that, even though they're immunocompromised, did have what was considered a seropositive response. But then they took that group that was considered seronegative and gave them a third dose. And so that's what you see on the far right here. And in these studies, people getting a third dose who didn't initially respond to the 2-dose series, among those who had no detectable antibody response to that initial vaccine series, about a third to half developed an antibody response to an additional dose. Next slide. And this is just looking a little bit more closely at that study, the first study that looked at the solid organ transplant recipients. So you see that, after that third dose, 1 month after the third dose, they had a good response. The other thing they found is that there were no serious adverse events with that third dose, and that in this transplant population, they had no acute rejection episodes. So next slide. So now I'm going to transition to the most recent recommendations. This is what we're hearing about a lot in the media right now, is around booster shots. So it's been recommended that Americans at highest risk for COVID-19, and this I will clarify is just for the Pfizer vaccine at this point. So those who received a Pfizer shot, those who are at highest risk for COVID-19 should receive a Pfizer COVID-19 booster shot to help increase their protection. And I want to go through these 4 categories. So the first 2 you see are people 65 and older and residents in long-term care settings should receive a booster. And then people age 50 to 64 years with an underlying medical condition should receive a booster. And you see I've highlighted should. And these are the 2 categories that have the best data, and that's why the recommendation is strongest in the using the word should. That's why it's strongest for those 2 categories. So then the second 2 groups are people age 18 to 49 with an underlying medical condition. So same as above, just the younger population. They may receive a booster. And then finally, people aged 18 to 64 years who are at increased risk for COVID-19 exposure and transmission because of their occupation or institutional setting, they may also receive a booster. And so with these second 2 groups, this is more of a, permissive, saying you may. It's not going to be, it's not against the recommendation, but it's not as strong because the data is not as strong. So the first 2 groups, or for all of these groups, there is data to show that there's waning immunity across all of the populations that have been vaccinated. But for the first 2 groups, that's where we're seeing data to show that these groups are actually having some increasing hospitalizations and deaths. So that the consequences for them getting a breakthrough infection are higher, and that's why you see the stronger recommendation. The other 2 groups, they are seeing waning immunity in those groups as well. But we're not seeing the more severe complications as a result of that waning immunity. And so these groups are eligible, but it's not as strong of a recommendation. So people could decide not to get a booster who are in those groups. Regarding that last bullet, giving some examples, the occupational or institutional setting, these might be healthcare workers or teachers, or people who work in prisons or homeless shelters would be an example of people having increased exposures and at risk for higher transmission. As I said earlier, our focus still at CDC is getting that remaining percentage of the population who haven't even had their first dose of vaccine. Another thing to emphasize as we approach the fall and winter respiratory virus season, which includes flu, we're encouraging flu shots as well. We don't know what flu season is going to look like this year. We didn't know what it was going to look like last year, and it ended up being a mild flu season. It was not mild for COVID, but it was mild for flu. And we think a lot of the measures that were being taken to keep people safe from COVID are also effective for flu. But this year's going to look different. I think there's not as many, people are out and about a lot more than they were last year. And so it's not clear what flu is going to look like this year. So we're really emphasizing flu shots, and they can be given with COVID shots, whether it's your COVID booster or your first COVID shot. You can get a flu shot and a COVID shot at the same time, just different site. You can do one in each arm, but they can be given at the same time. We've also released data that the safety for this third dose looks really good, similar reactions to what we see with the second dose. So people can be confident that getting that third dose, they're not going to experience increased side effects. Okay, I think that's all I have on that one. So next slide. All right, a little bit, I'm going to touch on monoclonal antibodies for both treatment and prevention among people who are immunocompromised. Next slide. So the monoclonal antibodies are currently authorized by FDA for emergency use in persons with SARS-CoV-2 infection who are at high risk for progressing to severe COVID-19 and or hospitalization. The recommendations around the use of monoclonal antibodies are really being managed out of the NIH, specifically the NIH COVID-19 treatment panel managing these recommendations related to both use for treatment and prophylaxis. And so the difference here is, so for treatment, obviously that's what I mentioned above, someone who's been diagnosed with COVID-19 who's at high risk for a severe outcome. For currently, the only indication around prophylaxis is for post-exposure prophylaxis. So this is someone who's not yet sick with COVID-19, but they've had a close contact to someone who does have COVID-19. And so it is authorized for prevention of SARS-CoV-2 infection, post-exposure prophylaxis. There's also interest in pre-exposure prophylaxis. So this is not presently authorized by FDA, but research is ongoing, and we expect that one or more of the companies might file for this indication. This would be someone who anticipates being in a scenario where they might have a high risk of getting COVID-19. So next slide. All right, I compiled a couple of frequently asked questions about vaccination in persons who are immunocompromised. So next slide. So first would be, which immunocompromised groups should be considered for that additional dose? So that's the first thing I talked about. This is not the booster for waning immunity. This is for the group of people who are not expected to have a good response to the primary series of vaccine. So this is recommended for conditions and treatments that are associated with moderate to severe immunocompromise. And this list includes solid tumor and hematologic malignancies, receipt of a solid organ or hematopoietic stem cell transplant, some people with primary immunodeficiencies, some people who are living with HIV, and then people receiving treatment with medications such as cancer, chemotherapeutic agents, TNF blockers, certain biologic agents, for example, rituximab, and high-dose corticosteroids. This additional dose is also recommended in some chronic conditions associated with varying degrees of immune deficit, such as asplenia and chronic renal disease. And then different medical conditions and treatments that can result in a widely varying degree of immunosuppression. And this is where a patient's clinical team is really going to be the best to decide and assess that degree of altered immunocompetence and the optimal timing of vaccination. Next slide. Another frequently asked question is, should immunocompromised people undergo antibody testing following their COVID-19 vaccine series? So a couple things to talk about on this. First, the utility of serologic or antibody testing or cellular immune testing to assess immune response for COVID-19 vaccination has not been established. Part of that is the exact correlation between what antibody level confers protection remains unclear. We don't know what that kind of cutoff point or level is yet. Also, those tests that are available commercially for antibody and cellular immune testing, it may not be consistent across laboratories. So the testing you get done at one lab versus another is not necessarily the same. So at this time, serologic testing or cellular immune testing outside of the context of research studies, which there is a lot ongoing, is not currently recommended. So what this means is we're not asking that physicians taking care of immunocompromised patients outside, as part of their day-to-day care, should not be ordering these type of tests. They really are still in the research realm right now. And there's active work going on to try to answer some of these questions, like what level means that somebody is immune. Next slide. I think we've probably touched on this a bit, but following COVID-19 vaccination, what infection prevention measures should people who are immunocompromised maintain? So really it's what we're telling unvaccinated people. Immunocompromised people should be counseled about the potential for their reduced immune response to a vaccine and the need to follow additional prevention measures and not relying just on their vaccine response. So this is wearing a well-fitted mask in public spaces, staying 6 feet apart from others they don't live with, and avoiding crowds in poorly ventilated indoor spaces. And then also encouraging, if haven't already, having their close contacts or household contacts of immunocompromised people should be encouraged to get vaccinated to kind of, produce that protective effect around the immunocompromised person. Next slide. Regarding immunocompromised children in school, we've had people ask, my child is immunocompromised, what can be done in the school to help keep my child safe? And it's really what I hope a lot of schools are already doing, which is to layer on the various prevention strategies that we know work, especially when they are layered on together. So requiring universal masking in schools, promoting vaccination for those who are eligible. And we know, I'm very well aware, I have 2 elementary age kids who are not eligible yet. So we know there are a large proportion of school students who are not yet eligible for vaccination, but those 12 and older who are, encouraging them to be vaccinated, as well as teachers and staff. Improving ventilation in schools, and then physical distancing to the extent possible, which we know is difficult in schools. If a school is not using these layered prevention strategies, it's really going to be important to ask about virtual learning options for an immunocompromised child who might be at increased risk for severe outcomes. Next slide. Okay, so finally, I have my last few slides. I understand this. You all might have some interest in long COVID. And as mentioned at the beginning, I did spend a few months working on this topic area. And so at CDC, we developed a term called Postcovid Conditions as an umbrella term for this wide range of physical and mental health consequences that are presenting 4 or more weeks after a COVID-19 infection. And we want to emphasize that this includes patients who may have had even an initial mild or even asymptomatic acute infection, but even these patients might be experiencing some issues long-term. Post-COVID conditions are associated with a spectrum of physical, social, and psychological consequences. And one of the things that has made it a challenge to study is that these conditions are very heterogeneous, meaning one long COVID patient does not look the same as the next long COVID patient. And the symptoms or the things that they are experiencing may be attributable to different underlying processes. We know that long COVID is being used by many patients to describe post-COVID conditions in general. So we recognize that term as well. Next slide. I wanted to show you a little bit of the framework that we've been using to think about post-COVID conditions and just how broad they are. So on the left, you see post-COVID conditions, and this is kind of, I think, early on, a lot of the work being done on long COVID was really focused on hospitalized patients, so people who had the most severe illnesses from COVID-19. And so this is an area where these are general consequences of illness and hospitalization that can occur regardless. So outside of COVID-19, anybody requiring hospitalization for a severe illness, particularly ICU care, can experience these types of consequences. So there's even something called post-ICU syndrome. But things like healthcare acquired infections, side effects of medications. These are all things that COVID or other things can be long-term consequences and complications after a hospitalization. On the other side, we have things that are more specific to the SARS-CoV-2 infection. So some of these are system specific. For example, people who have had permanent lung damage from their COVID infection, lung fibrosis, people who have had strokes in association with their COVID-19 illness. That's one group we see over here. The other is a group of people experiencing clinically significant symptoms that don't have a clear pathology. These are kind of what we've been hearing about. I think this is where the term long COVID tends to apply. People who are having kind of these shortness of breath, fatigue, brain fog, these kind of symptoms we've been hearing about that don't have a clear explanation. A lot of these are also similar to NECFS or myalgic encephalomyelitis or chronic fatigue syndrome and dysautonomia patients. And then there's a group of people where there might be some objective findings on, say, some sort of imaging or other diagnostic tests, but there's an unclear significance to them, clinical significance, and these are what we kind of call incidental findings in medicine. One thing I want to emphasize is that these conditions can frequently overlap, and patients may experience any combination of these, within this framework. Next slide. People might also experience worsening of their pre-existing conditions or disability as a result of their COVID-19 illness. And the rest of this is a little bit about what I already talked about. Some of this is a result of direct organ damage. We've documented effects of the virus on lung, heart, kidney, nervous system. Hypercoagulability would be the strokes and the pulmonary embolus that we've seen in association with COVID. And then these debilitating symptoms without medical explanation, which I mentioned, the fatigue, the cognitive impairment. And then not to be ignored, the mental health consequences of people experiencing anxiety, depression, and PTSD, both people who've had COVID and then, just as, people who didn't actually have the illness, but have, all of us that have been living through this pandemic, we don't want to ignore the impacts that have been experienced on mental health. Next slide. I want to, as I mentioned, I worked on this topic and started on it late last year, where the research that was being done, there was just so little data to go on. And as I mentioned, it was really being done in more of the hospitalized setting. So my group actually wanted to look at long COVID in non-hospitalized people, people with COVID, but were not hospitalized, and to look at what they were experiencing longer term. And so we partnered with one of the Kaiser health systems and used their data to look at their COVID-19 patients. And we found that non-hospitalized adults with COVID-19 had higher healthcare utilization 1 to 6 months after their initial diagnosis. We found 2 out of 3 had at least one outpatient visit 1 to 6 months after diagnosis. And this analysis used ICD-10 codes, which we know have limitations, but using those ICD-10 codes, we saw that some of the new symptoms people were being seen for included cough, shortness of breath, chest or throat pain, and fatigue. And that kind of on the positive side, we saw that the frequency of these visits for these symptom diagnoses decreased after 60 days, but did persist beyond 120 days for some patients. And that's consistent with ongoing research showing that a lot of people do experience improvement over several months, up to a year out. Some of them will experience improvement or resolution of symptoms over time. Next slide. We were also hearing from physicians that we're starting to see these patients in increasing numbers, asking questions. What do we know? What is causing this? What can we do for these patients? And so in response to that, the group I was working with developed and released interim guidance for post-COVID condition clinical care. There's a lot we still don't know, but there were some things we felt we could say about taking care of these patients. So a couple of highlights from that guidance were that most post-COVID conditions can be diagnosed and managed by primary care. So a lot of people are not going to need to be seen by multiple specialists. And most of them can be diagnosed based on history and physical exam. A lot of routine laboratory testing may be normal. And so considering a conservative diagnostic approach in the first 4 to 12 weeks after their initial infection is probably going to work for most. So not sending them for a whole bunch of testing. However, if symptoms do persist beyond 3 months, that can prompt a further evaluation. And one of the most important things is, a lot of these patients early on, I hope that this is improving, but a lot of patients early on were being told that these were just, tests for comeback or they would come back, without any major findings. And so I think some people were being told this is just in your head, you're not actually sick. And so emphasizing that these patients should be listened to and validating their experiences and partnering with patients to identify achievable health goals is really something we're trying to emphasize in managing and taking care of post-COVID patients. Another thing to highlight is, I mentioned we used ICD-10 codes in that previous analysis, which have, and we were using kind of symptom codes that, for things we had seen in the literature that people were experiencing with long COVID. But as there still wasn't an ICD-10 code for a post-COVID-19 condition. But that should be changing. And I think if things are still on track, we should see that code released in the coming weeks in October. So that'll really be helpful, particularly on our side when we're using these data to try to track what, trends to be able to have a specific code for post-COVID will be really helpful. Next slide. So just a couple of things to reiterate. As I mentioned, testing is often normal and there's no laboratory test or biomarker that's going to distinguish post-COVID conditions from other etiologies. So, oops, pull my slide back up. The other thing to emphasize is people do not need to, particularly early on in the pandemic, there were people that did not have confirmatory laboratory testing done to show that they had COVID-19. And that might continue for people who maybe had a very mild infection and didn't actually seek testing. That doesn't mean that they don't have a post-COVID condition. A confirmatory test showing that someone had COVID-19 or showing that they have antibodies is not necessary to make a post-COVID diagnosis. So I think that probably brings me to my last slide. Let me just double check. Next slide. Yes, so just a few slides on references. But yeah, that's what I have for you today. And I'm happy to try to answer any questions. I don't promise to have all the answers. If I don't, I'm happy to kind of take your question and find the answer out for you. So thank you.
Well, thank you so much, Dr. Cope. That was really such a thorough and just enlightening conversation and presentation about where we are currently. And I was actually going, I had a couple of questions queued up and you had them all answered in some of your frequently asked questions. I think there might be some people that have some questions. I think we should do it like this. We only have a couple minutes left. If you could please type your questions in the chat. And then I'm going to just have Dr. Cope go through and answer some of those. But while you're doing that, I did want to highlight one thing here. I am a part of the Immunocompromised Collaborative, and I think Lynn Albizo is on here too, who runs that collaborative, and she's been doing such a great job with the CDC, particularly around persons who are immunocompromised. And I know Dr. Cope, your colleague, Dr. Hicks, spoke at that meeting, and I know there's a number of groups on here too. And so I just wanted to highlight that group. And Lynn, not to put you on the spot, did you want to say something to plug the collaborative? I think there could be, I know some groups here in our in our coalition that are a part of that. Are you there, Lynn?
Sure. Yeah. Yes. I appreciate the nod and appreciate the presentation. Lori had presented a similar presentation, and it's good to see that you built upon that. So really appreciate the continued engagement with the CDC. And just to let everyone else know, Brett is part of our steering committee. We have monthly meetings. The autoimmune community is very engaged. The Lupus Foundation as well. I know Pat is probably on here too. Is part of the steering committee as well, and we've are advocating for the needs of individuals who are immunocompromised, and of course, specifically right now, all the issues related to COVID. So if you're interested, I'm sure Brett can connect you with me or email me at the Immune Deficiency Foundation. And just want to point out, we are not, the primary immunodeficiency is not an autoimmune disease, but we are part of, we're a member of, now that ARDA, or the new name, is it just autoimmune?
Yep.
The Autoimmune Association. That's actually easier. And but a big reason for that is that many people, and we're finding more with genetic testing, et cetera, that have primary immunodeficiency also have autoimmune diseases. Great. So thank you for that nod, and please reach out to me if you're interested in the collaborative.
Thank you, Lynn. I appreciate that. I wanted to highlight that because autoimmune diseases come in a lot of different shapes and sizes and severities. And so the immunocompromised portion's an important part of that. I think, so we have a couple minutes left here. I will turn it back over to you, Dr. Cope. Is there any, I think we have a few coming in, anything that you see there you'd like to comment on?
Yeah, I'm seeing a couple maybe getting at booster stuff, and like, I know it's a hot topic and there's much more to come. So, I think someone's picking up on the fact that the current booster vaccine or recommendation is just for the Pfizer vaccine. So my understanding is there's probably more to come soon on Moderna booster. So the current recommendation is just for Pfizer, but stay tuned. I think we will see soon. If I'm not mistaken, I believe that data is currently with FDA for review about boosting for Moderna. And let's see. Someone also asked about mixing vaccines. I know that is also, that is something that is actively being looked at. And there is some data out there now to show that, that there's the potential to be able to mix vaccines. I think from a purely practical standpoint, in that, I got Pfizer but Moderna is the one for my second dose that's the easiest for me to get, is that possible? Does mixing the vaccines actually enhance the immune, give you a better immune response? So lots and lots of active ongoing research there. And I think, again, more to come soon on mixed series of vaccine. I see one. How long does someone that was unvaccinated and had COVID, how long are they infectious for? So this, I guess the short answer is that varies. But from what we, the data shows, and this relates to our, recommendation that people who, obviously someone who has COVID is asked to self-isolate, and they can be released and end that isolation 10 days from when their symptoms, if their symptoms resolve, and then 10 days have passed since they first started having symptoms, that's when isolation can be ended. Or if they were someone who's asymptomatic, if that clock would start from when they first had that positive test. And that 10 days is based on the majority of people are no longer infectious after 10 days. However, as I pointed out on one of my slides, in immunocompromised people, that's where we're going to see some of that prolonged viral shedding. And so we have seen some people who are, extend well beyond that 10 days, somewhere in the range of 20 or 30 days. And so that's why that there's the caution there. And so someone who's immunocompromised that might be an instance. For most people, we don't recommend that you need to be tested to come out of isolation, that 10 days is sufficient without necessarily needing a test. But in someone who's immunocompromised, that might be where getting some additional testing to confirm that they're negative might be warranted. Let's see.
Well, I think the last one here, maybe the safety, maybe speak to that just in that. And I think that's
the vaccines and antiphospholipid syndrome. So I'm not aware of any. Yes, vaccines are safe. I am not aware of any specific condition that we are saying that someone shouldn't be vaccinated. That being said, you should certainly discuss, your specific situation with, excuse me, your physician.
Great. Well, thank you. Thank you so much, Dr. Cope. This has been really great. And then, on behalf of the Autoimmune Association, I just want to thank you and the CDC for the work, the very important work that you do. It is really critical. And I appreciate you taking the time in your busy schedule to talk to us. So thank you so much.
Thank you for having me.
Okay, great. All right. Well, thanks everyone for joining. I appreciate you taking the time as well. We've recorded this and we'll have this to send out to those who may not be here or have asked for it afterwards. So thanks again. And we'll talk again soon. Thank you.